All right. Hi, everyone. Good morning. Thanks for joining our session. Can everyone hear me? Yes. Okay, great.
Yes.
I'm asking because we were having a little bit of problem getting on. So sorry for the delay, but welcome to the session. And we are going to, the session title is Who Will Pay My Bill? And as you know, this is really important topic for all of us because many times, not for just sickle cell disease, but for other medical conditions also, many times we need to be seen in the hospital for sometimes for maintenance of health, sometimes unfortunately when we are sick, or sometimes we need some other services. So the question comes up how to navigate the system. And as you can imagine from your experience, and I'm sure pretty much everyone knows, it's not straightforward. Although I'm in medical field, I sometimes don't know how to handle the situation. So we'll start our panel, and I would invite all the audience to please send your question using the chat box so we can answer them. So first of all, we'll go ahead and introduce everyone. So if you can please go ahead and introduce yourself, please. Ms. Biko.
Hi, I'm Dorina Biko. In real life, I work for the Institute for Defense Analyses, but I'm also a parent of a child with sickle cell.
Hey, good morning, everyone. My name is Jose Diaz Luna. I am a pharmacist by training, and I am a management in a managed organization pharmacy department.
Good morning.
Okay, go ahead, Cynthia.
Okay. Good morning. I'm Cynthia Gibson, and I'm the founder of the Christopher Gibson Sickle Cell Moya Moya Foundation. And I'm also the family advocate in the pediatric sickle cell department at Howard University.
Ms. Nivia.
Hello all, my name is Nivia Charles. I am a student at Howard University studying community development. I also work with the Howard University Center for Sickle Cell Disease as a community outreach assistant, and I am indeed a sickle cell warrior. Nice to meet you.
Hey, Max, go ahead.
All right. Hi, everyone. My name is Max Wolf. I'm a registered nurse at Children's National Hospital in DC, and am a clinical program coordinator for the sickle cell program there.
Shanetta, you want to introduce yourself, please?
Hello, everyone. I'm sorry. Hello, everyone. I'm Shanetta. I'm a sickle cell warrior, and I'll be moderating the question and answer session.
And I'm Deepika Darbari. I'm one of the hematologists who had worked at Howard, and at this time I'm at Children's, and it's my honor and privilege to take care of children who have sickle cell disease. So thank you all for joining the session. I'm going to share the screen so that audience can see, where we are, and so they can understand our conversation. Can you see the presentation? Are you able to see? Okay. So we heard who are our panelists. Are you still able to see my screen? Yes, okay.
Yes, we can.
Yes. Okay. So our first of the things I would like to talk about and ask, hear from the panel, whenever we try to get health insurance or looking at different insurance plan, it's kind of, multiple acronyms put together. And many times it's very hard to understand what they mean. So I was wondering if Jose can introduce us to what are the different kind of plans. When we hear MCO, HMO, what do they mean? And what are the different what are the certain things that we should look for when picking up an insurance plan?
Well, sure. Managed organizations refer to more like the companies that the different state, in our case, the District of Columbia, will hire to manage the Medicaid population that is not in the fee-for-service. The fee-for-service is what people would call straight Medicaid. Those enrollees are managed directly, and all their bills paid directly by the District of Columbia. The managed organizations are are contracted by the District of Columbia, normally on a 5-year contract. Currently, there's 3 managed care organizations in DC. There's AmeriHealth, Caritas, Care First Community Health Plan, and MedStar Family. Those managed care organizations are not only like people saying just pay bills, they really had to, there's a lot of requirements, managed care, including case management, outreach, promotions, everything that they have to do. They have to, assign the enrollees to a primary care physician. They are, required to follow up after discharge, those kind of things. So it's a lot of services that the managed organizations provide. Unfortunately, oftentimes the patients do not know that. We know that, the companies will send mailings out, an enrollee packet, one thing. We don't read most of anything. I know I don't read my own stuff that comes from my health plan often. So there is a lot of services that are provided by managed care organizations. An HMO, health maintenance organization, and PPO are pretty much the same thing. They're commercial plans, but the health maintenance organization, HMO, will require that you see in-network providers. So you have to see their providers that are in their network. And if you go out of that network, the services may not be covered, or you may have to pay a very hefty fee to be able to get those services. A PPO is a preferred provider organization, and that gives you the leeway to see who you want to see, and they will pay for it. In terms of the benefits are usually the same. The difference is that you actually get to choose. Let's say for some reason, you were employed by company A and you were with certain insurance, and you had a physician that you already seen, a specialist, and now you're employed by a different company, different insurance company, and that person is not in the network. Obviously, you will have to change your specialist. That's, for a condition like sickle cell, you don't want to be changing your physician. You want somebody who knows you and you have a relationship with them. So that will be the benefit of the PPO, that you get to keep the physicians that you want.
So if I'm picking a plan as a patient, if I need to get some more information about the details of the plan, what would be a good place to start?
Every health plan has a website, and they will explain, what the different benefits and tiers or copays are. If you're getting your insurance through your employer, definitely during the open enrollment season, they will give you all the details of whether, what is in network, what is out of network, what the copays are, what the maximum, in a Medicaid MCO, there's no financial responsibilities on the enrollee ever. It's 100% the responsibility of the health plan. Commercial health plan, we know that we have copays, we have limits, and all those things. So you have to look at the health plans and see what is it that you're going to get, what limits you have. You have to consider your different hospital visits, your the specialists and PCP visits, your pharmacy spend, to make sure that health plan that you buying will cover your needs. Otherwise, you're going to end up, half the year, 3/4 of the year, that you run out of benefit because you already missed your cap.
Yeah. Thank you so much. That was very helpful. So next, can our panelists who have personal experience with problems or certain kind of problems with the coverage related to services for sickle cell disease, would you like to share some, please?
I can start. Being a patient with sickle cell disease, there is a number of tests and different treatments that are necessary just to maintain a semblance of health. Not having adequate coverage to make sure that you have access to these things can pose a great detriment to health. I've had numerous experiences where I may have built a relationship with some type of physician or healthcare provider that may be out of network, but they know very well how to treat my personal conditions, whether it be chronic pain or sickle cell anemia specifically. Not having access to the coverage or not knowing who is inside or out of network prior to getting treatment is something that is a huge issue that I've experienced for sure.
Thank you. That's very helpful to know. Anyone else?
I'm happy to share. Some of our problems that we've experienced have come with, covering the costs of either new medications or even medications that, like opioids. which understandably, are much more tightly regulated, but are, play a different role in the lives of sickle cell patients. And so either, having to go back, to our physician to kind of justify, why our daughter needs that. Fortunately, we haven't been denied, but sometimes they're just extra hoops. And sometimes when you just really need the medication, it's just an extra hassle. Some of the new medications that like Ciclos, which is very convenient because you can break it up. Our daughter's 12 and can't quite swallow the bigger hydroxyurea pills. That has, it's very expensive and it is not completely covered by insurance. So that makes it harder to really take advantage of what could be a really great advancement in medication, for treating sickle cell.
Just a quick comment. You mentioned pain medication and opioids. Obviously, every health plan and every clinician right now really is paying attention to the amount of morphine mill equivalents that you have, and the DC. For the Medicaid population, all the fee-for-service and the MCOs should be following the same guideline for the opioids, and patient with some pre-existing conditions should not be tied into those guidelines. So if anyone, with sickle cell or is a resident of long-term care, palliative care, there's different conditions that those edits are not to be used for you. So if there's a rejection in the pharmacy saying, oh, this is more than 7 days supply, there's definitely something wrong, and that should be corrected easily without having to go to a lengthy prior authorization process or anything like that, because those patients should not be subjected to them.
And I would like to add that, and a lot of this confusion came from the CDC guidelines a few years ago. And then after that, American Society of Hematology, and along with many members from different groups, and since sickle cell falls in the hematology conditions, so we had a meeting with the CDC guidelines, and it was amended. So if any of us hear this problem about opioid and restriction, as Jose mentioned, it's important to point out the sickle cell disease has been excluded. So if you look at the guidelines, and I'll be happy to share with individuals if they want, like an amendment of the guidelines. So it's a very important point, Jose. Thank you for bringing it up. Ms. Gibson, do you have any comment?
Yes, I do. One of the areas that I had encountered is dealing with specialty pharmacies. Because like my son at one point had to use Desperol because he had an iron overload. And I couldn't just go to the regular pharmacist to get that, get the medication. It had to go through a specialty pharmacy, but his medication was delivered to the home. And the other thing I found that it's with the specialty pharmacies, when we have our kids and they have to have like compound drugs. And when you think about a compound drug, I look at it like you're making a cake and you got all of these different ingredients going into this medication. So you have to find a place that will prepare these, and those pharmacies seem to be far and few in between. And also, even if you want to get a medication changed from a pill to a liquid, and sometimes the pharmacy will balk about it because the person is a young adult or an adult, and they fail to realize everybody can't swallow these pills. So they would need a liquid where they just want to give the liquid to the children. So, we just need some more support and guidance on dealing with these specialty pharmacies and knowing where we got to go. And also, it seemed like most of the drugs that go through these specialty pharmacies, the price is ridiculous. And unless you have Medicare or Medicaid to pay for it, if you got commercial insurance, you're looking at a big copay in order to get these drugs. So, as parents and also providers, we need to know where to send our families to get that extra assistance they need to pay when you have a huge copay.
Yes,
Thank you so much.
I
Yeah,
want to
that
touch.
that is, no, sorry, go ahead, Jose, please go ahead.
Just want to touch up on some of the comments you made about specialty pharmacy. They're definitely on point. And the well, a few things is that a lot of these new drugs, specialty drugs, some of them are in what is called a limited distribution channel. So not every pharmacy carries a product. The pharmaceutical company have decided that only certain pharmacies will carry the product for one reason or the other. Also, you have health plans that have one specialty pharmacy in their contract for terms of pricing and location and whatnot. So yes, it's there are barriers, to specialty pharmacy, and they're all based on contracting. They're based in location. What I always suggest, patients is to make sure that the physician that they're seeing or the local support groups have a relationship with local pharmacy that can support them. Always, as I said, there's always a reason, and there's always an opportunity for a third party company to contract somebody else because there's a need. I mean, if there's a need in the community for this type of service, and even though you have a restricted supply or whatever it is, there's always a way to do things. So I will say, always contact the patient advocate and deal with it. Normally specialists have a relationship with pharmacies that can dispense and compound the product that they need. So I'll say they have to have a very good communication with the office staff that takes care of those matters, because it's, taking a compound to any pharmacy, they may not be able to do it. So, usually I will ask, where do you want me to take the prescription? Or I ask them, can you fax them the prescription or call the prescription into the place that can do it? Because it's hard for the family to drive around the city trying to figure out who's going to fill this prescription.
Yeah, and that's really important point, and especially as we heard from Dr. Cato this morning about different medications, those are available. So we are lucky to have Max Wolf with us, who deals with this kind of issue every day. So maybe we can learn from Max. How, if we write a new medication, so suppose Oxbrite or Adakveo, how does the process work? And sometimes not even just new medication, but as Ms. Gibson said, pills versus the liquid or the compounded medication and things like that. So please let us know.
So I'll start by responding to Ms. Gibson's concerns about the compounding, because we run into it a lot with hydroxyurea, because it is a chemotherapy ultimately and does need to be compounded under a special type of hood. And unfortunately, in suburban and rural areas, those are, as Ms. Gibson said, very few and far between. We are lucky to have a pharmacy in our area in Maryland. Of course, the name of the town is escaping me right now, but it's called East Pines, and they do send medications out at astonishingly far distances from themselves, which is great. And they do take insurance. Most of the insurances that our patients have, which is very helpful. But if we have patients that don't live close enough to have them deliver, or patients that have issues having their medications delivered to their door, our options become more limited. So what I usually do is I just Google compounding medication or compound pharmacies, and I'll just call around, or if I don't have time, I'll send the family a list and have them call and ask and tell them what questions to ask for hydroxyurea compounds. And we've been able to work together to find pharmacies for most of our families. But the other issue that you run into is not just that the commercial insurances end up having to pay a higher copay, but also that a lot of them that I've found don't even take insurance for compounds. And I'm not sure why that is, why some do and some don't. But that's another issue I've run into. And unfortunately, I haven't really found out why. But in terms of how it works with specialty pharmacies, when you prescribe a new medication like Oxbryta or Ciclos, we will get a prior authorization request. And me and my nurse coordinator colleagues take care of that. And we have to fill out the PA form and include justification for the medication, as well as documentation of the patient's diagnosis and labs, history, what have you, that will prove to the insurance company that they need that medication. That process takes anywhere from 5 to 10 days, normally up to 2 weeks. For the more expensive medications, usually those are like the infusion medications, like Adakveo. I don't personally take care of those medications. That goes to our payer clearance team. Thankfully, because we do have so many patients on medications like chelation, iron chelators for our patients on transfusions, long-acting pain medications also require them oftentimes, and our chronic pain patients often do need to be on those periodically. So those come up.
Max, can I ask you a question related to that? So suppose
Sure.
I'm a patient where my physician thinks this is a new medication or this new formulation would be great for me. So, and they want to start the medication. So where do you suggest I start as a patient? My medical team or?
Yeah, so if you see a new formulation or hear of a new medication that you'd like to try, you would just start with your medical team and discuss it with them. You know, we can help find out, you know, where the medication is available. Like Jose was saying, some of the newer medications aren't widely available at all pharmacies. We'll have to do our due diligence to find out where you would be able to get it. Most pharmacies will order new medications for you, but as the patient, you would have to be responsible for requesting your refills far in advance so that they have time to order more of it for you before you run out. Those are just some examples of things that will come up with newer medications. But you would start by discussing the medication with your medical team, would then decide if it would be a good option for you. We would then prescribe it, do the prior authorization if it's required for your insurance. And then comes payment. For Medicaid programs, they don't pay co-pays, so that's not an issue. They're either denied the medication or granted permission to receive it, and they receive it. Patients that have private insurance or commercial insurance do have co-pays, and as Biko mentioned, Ciclos. This is one of my biggest pain points, because Ciclos would be such a nice drug for us to offer people that don't have access to a good compounding pharmacy. But if they have commercial insurance, the co-pays range from $50 to $250, and $50 is pushing it for most people to pay per month for hydroxyurea, which has been around forever. They use the formulation all over Europe and have done so for years. So it baffles me why it costs so much for our insurance companies to pay for it. And unfortunately, the company that makes it does not have the best copay assistance program. I have tried to use it, and they basically give you a network of pharmacies that work with them in their copay assistance program. And almost every time I've had the prescription sent to one of those pharmacies, when the patient takes their copay card in, the pharmacist has no idea what it is and they don't end up getting the discount. So I've communicated this with the Ciclos rep before, and I just haven't used it again in recent times because we haven't really put as many kids on Ciclos lately, but that's one of the issues that comes up with payment. And then delivery, some things to look out for when you do end up getting prescribed the medication and we get approval, is you need to be on the lookout for a call from the specialty pharmacy. A lot of times this, kind of getting started on medications gets delayed because the patient sees an 800 number and they think it's a telemarketer and they don't want to answer those calls. And then nobody checks their voicemail anymore unless it's for work. So a lot of times voicemail boxes are full and messages don't get left. So something that you should remind your patients of is if you see an 800 number after you've been prescribed a specialty medication, you should probably answer it so that you can set up delivery and all that good stuff. And then again, remembering that since the medication is being delivered to your house, which is great, remembering to request your refills before you run out of medication because it will take a few days to get to you. I think.
One thing to add to what Max was talking about, and especially hydroxyurea and some other products that are very old and inexpensive drug, is when you have, the government agencies, FDA and pharma is going to go out and find a product that is in the market, and they're going to find a formulation that is not in the market, has been compounded at a very inexpensive cost to anybody, and then they get a patent on a drug because they formulated this drug, and now it becomes $1,200, $1,300. We've seen that with not only with hydroxyurea, but if you're talking in pediatrics out of the children's hospital, a lot of lisinopril and those that were being compounded at the local pharmacy now cannot be, because there is an FDA patent on a drug that is being manufactured by pharma at $1,200. And if you have a family that is paying out of pocket for this lisinopril, they could have gotten that prescription made at their local pharmacy for $20 some dollars. Now they cannot do it because the law says that the pharmacy cannot compound a product that is available in the market. So you cannot compound a product as long as there is a product, the same product in the market. So we went through that with Makina, we went through that with now we're going to with Cyclo, with lisinopril. It's part of the the actual regulations that allow to happen with medication. I as a pharmacist myself do not believe that the FDA should grant a patent to anyone for a drug that has been in the market for 20 years and is very inexpensive, and all of a sudden come up with a cost of $1,200, $1,300, $5,000. It just doesn't make sense.
Yeah. And I think prior authorization, Max, you brought up many good points. So, how to start if a new medication or even old medication, different formulation is prescribed, how to navigate the system, but also prior authorization. So the audience know many times, not just for medication, but for some testing we need. And as Dr. Rana mentioned in his chat, it really takes a lot of time. So really we want families to work with us so that they also understand and they can talk to their insurance company. So Max, there's someone, and we heard about bone marrow transplant today. And I'm sure like many of the audience may be thinking that this could be option for them. And for what are some of the other things you often get prior authorization for, like genetic testing or HLA typing or things like that?
HLA typing does require prior authorization for a lot of insurances. And we run into problems with priority partners insurance a lot, and they actually they won't pay for any bone marrow transplant related testing or procedures at our hospital. They require everybody to go to Hopkins, which becomes an issue if your primary hematologist is at Children's and you have a perfectly good bone marrow transplant program at your hospital. So that's prohibitive if the insurance just won't work with a certain facility. Luckily, that's the only insurance that we run into that with. And then we also run into it a lot with some diagnostic genetic testing. For example, in infant clinic, we often see the need to test our youngest patients for what is called hereditary persistence of fetal hemoglobin, which basically, if the child does have this genetic trait, it drastically changes the way that we treat them. We don't require them to have transcranial Dopplers annually. We don't put them on hydroxyurea typically, unless of course the course of their disease course later in life changes. It reduces costs for the insurance company ultimately because they're on medication and they're not having expensive scans done annually. But a lot of times insurances will deny us this testing because the test itself is expensive, but not as expensive as the long-term care of somebody that may not even need the level of care that they're getting. So does that answer your
that's
question?
great. That's very helpful. Thank you. So I just, we want audience to know the prior authorization is not just for medication, as Dr. Rana mentioned, but many of the diagnostic testing, even admission, we have to justify the admission. So we, on the physician side, also, there are many of the barriers that we face taking care of kids with sickle cell. Other thing, Jose, one question for you is someone asked in the chat, is there like a difference in the cost or copay when it comes to the hospital pharmacy versus a retail pharmacy outside? Or should it be the same?
The copay is established by the insurance company, not by the pharmacy that is dispensing the medication. So if you're using the hospital outpatient pharmacy, or you're using a local independent or chain pharmacy, your copay should be the same.
Okay. Does anyone else has any question? Ms. Gibson, Ms. Nivea, Ms. Biko?
I wanted to circle back about the copay assistance. I, got caught up in griping about the sicklos one, but there are a lot of great copay programs out there. And the best way to find them is to either ask the pharmacist that you're speaking to, either at a specialty pharmacy or like a local CVS or whatever. Those are great. Those people are great resources to get you hooked up with a copay assistance program. And if you have nurse coordinators, we often have a pretty good knowledge of what you need to do to get copay assistance. And if you look at the medication that you're taking or have just received and you have a copay that you would like help with, you can look and see what company makes the medication and then go to their website and see if they have any copay assistance available for that medication.
One question I also have is many times, our families live quite far and they may have problem coming to their appointments and things like that. Are there for other services, and how can we approach those and make sure that they are covered something like transportation to the appointment, physical therapy. So that's one question. And second thing, I also want to know, many of the chronic condition, they sometimes need counseling, mental health support and things like that, and which typically are not very well covered. So do you have any advice for us, Jose? And panelists, please feel free to ask any question. It's an open session for all of us.
Yeah, I can speak for the managed care and fee for service that transportation to and from medical appointments is always covered. And that extends, I believe that now it extends to the, periphery of, Southern Maryland and Northern Virginia, because, some of the DC residents do have to go either to Maryland or Virginia to see their specialist or whatever. So those services are covered. It's all done through the case managers or the family, the enrollee, calling enrollee services and say, I'm in need of transportation, even to pick up a prescription to the pharmacy. We do have, a lot of pharmacies, in the District of Columbia, Maryland, and Virginia that do free home delivery. But if that is not a choice for one reason or the other, you can also get an appointment, free transportation, to go to the pharmacy, definitely to go to your hospital visits, any physician visit. There's a lot of work done in the district and not in this role altogether, to really bring mental health parity to medical. And that, that's one thing that I myself promote and really work on it, because you have to realize that people who have chronic conditions, that not only the patient and so the family is going to need some kind of support. So you need to be, we cannot treat family members if they're not our enrollees, but we need to at least be able to guide them, given information. Hey, this is available for you. Normally, if we manage care, the entire family will be with the same organization. Try not to split families. And so those services are there. It's case management, behavioral health case management, a lot of support for them. Like I said, again, it's like the families and the enrollees not knowing everything that is available to them, but there is, of course, along with physical therapy, rehabilitation, all those services are available. I mean, in the District of Columbia, we had the two different populations that go into managed care. We had the Alliance population, that some people don't even know what Alliance is. Right now, Alliance is mainly covering people who do not have a legal status as a resident in the United States, so that the District of Columbia pays for all their benefits, and the benefits are almost the same as the Medicaid enrollees. There's a few differences on it, and depends on where they can or cannot go, in terms of out-of-network services for one reason or the other. But there are, even for families who are struggling and may not know or understand that there is a free medical plan that they can't get through the DC Medicaid office, Alliance, and it will give them a lot of benefits through the managed organization that are equally to the regular TANF benefits.
Thank you so much for your effort, Jose. And I think I also want to speak to our audience, like mental health has been considered by many as stigma, but it's not. Like, anyone with chronic illness or even without chronic illness can experience these kind of problems. And there should not be any hesitation in accessing these services. Because that would help with the compliance with medication and so many other things, and overall will help improve the health with sickle cell disease. So I really urge everyone to consider those services when available.
Now, along that line, one of the things, my son had to deal with some mental health issues, and one of the things that his therapist told him, you're coming here to learn how to cope with your disease and to cope with getting along in life in general. So when he first heard about having to go see a therapist, he was afraid. He said, well, they think I'm crazy. So I think if we would, explain it to our patients, it's a coping mechanism to make our life a little better. We may be able to get more of our sickle cell families and patients to participate.
Thank you so much. And I agree, coping is so important. We all have, no one in the world, everyone has some problem. So I think it's very, very important to learn how to cope with it. And I want to address a comment by Nivea asking about non-pharmacologic problems like non-pharmacologic therapies like acupuncture, massage. And I'm happy to announce we have recently started a clinic like a couple of years ago for children with sickle cell disease, which is called Integrative Clinic. And we offer all these services, acupuncture, massage, aromatherapy, and also integral part of that is psychological counseling. So stressing how to cope with the problems or how to cope with pain, how to improve the compliance with medication. And I hope right now, those are just offered in our clinic, but I'm hoping that we can do more research, and that's why it's important. So these services are covered across the board, and you don't need you don't have a lot of problem accessing those services. So it's 11:20. If anyone has like final comments, please go ahead and share, especially our panelists, parents and families.
Well, I would just like to say, I appreciate everything the panelists had to say because there was quite a bit of information I got from this. And I was also looking at the chat. And even though a lot of the questions didn't get answered, they'll still be in there and we can go in later and check out and answer some of those questions for you. So don't feel that, you were being overlooked.
Yeah.
I did want to say, since Deepika brought up the integrative clinic, I saw somebody Christopher asked, how would you navigate assistance in paying for holistic treatments as well, such as acupuncture, massage, mental health, meditation, etc. You can always call your insurance plan to ask what your coverage is if you are not sure. Unfortunately, acupuncture is not widely covered, but there is research being done outside of our clinic and within our integrative clinic to prove that those services really do help with pain and stress relief. So hopefully in the next few years, there will be more coverage, but definitely never hesitate to call your insurance company to help you sort out what's covered and what's not.
Thank you everyone for joining the panel and audience for participating, which was a great learning experience for all of us. And our final message is this is just a start. So please keep the conversation going with your medical team and also with your insurance company. And don't hesitate at all to reach out to your team. They are there to support you and they'll find the best way to manage your condition. Thank you so much. Thank you.